So the topic that I'm going to be speaking about is basically a Hammerless solution to the sinus, but we can't talk about solutions to the sinus without dealing with all the different types of classifications that we have for the sinuses. And they can present in 4 different ways. We can have a high and wide sinus, which we can treat one way, a low and wide sinus. We can have a high and narrow sinus, or a low and narrow sinus. And each one can be treated very differently. It's a very different animal to treat a high and wide versus a low and narrow sinus. So you can't just have one tool for every procedure. We need to be able to adapt and have some variations in our techniques so that we can provide the ultimate for our patients. So my topic is going to be on the Crestal solution for this. And my main goal for that is to eliminate hammers. I'm not a big fan of hammers. I live in New York, and in Brooklyn particularly. And if you hit somebody with a hammer, they usually come back at you with a knife or a gun. So I try to avoid these dangerous instruments around my patients. So alternatives to the sinus is also a solution. Sometimes we don't have to be able to place a sinus lift. We can just place an implant. And there are many different solutions in terms of angled implants, whether they be the all-on-4 concept, the pterygoid concept, zygomatics, or tilted angled implants. And there's much research on this over the many, many years of these types of techniques. This is another case that we did in the office, just trying to show some angled implants. This is one that was done by my predecessor in my office, and you can see he got away with this for many, many, many years. This case is almost 25 years old. So it can work. It's not necessarily ideal in every situation, but we can be able to treat these in different ways, and there's much literature on this, going all the way from Palomalo's research into today's research that we have to keep developing different techniques, because ultimately, if we can avoid the sinus in situations, it's probably a good idea to try to do this minimally invasive dental concept. So dealing with the high and wide sinus, we're not going to shy away completely from the sinus, but we can get quite close to it by using a short implant. And short implants are nothing new. If we have very small amount of bone, we can simply stay just short of the sinus, something that Bicon has been doing for many, many years. This is a case that was done by Sheldon Lerner, owner of Blue Sky Bio, where I have many of his patients from my office. And this case is now 13 years old with great, great, great success. And we have many of those types of cases. So short implants are nothing new. There's much research on that as well, going from Anitwa and Huma Zadeh and Stephen Wallace and Stuart Fromm, all giving us the proper information about it. The crown-to-root ratio on implants is no longer really a concern for us, especially with the newer cone morse type of technologies. And I do highly recommend watching these 2 videos that are on the Dental XP website by Eduardo Anitiwa and Huma Zadeh on short implants. It will open your eyes up to what the wonderful things that can actually happen with short implants, not just in the posterior maxilla, but as well as in the posterior mandible, avoiding the infraalveolar canal. So for the class 1, we can always use short implants, but let's jump to the class 4. In the class 4 low and narrow technique, the main solution for many, many years has been the lateral sinus wall approach by using a Coldwell loop type of technique phenomenon and lifting up and going into the membrane, described by Hilt Tatum, Boyne, Mish over the years. And we have heard this yesterday from Dr. Kazemi's lecture, which was very outstanding. But there's a main goal that we have to understand, the reason for the lateral approach and why it's so successful. Once we have our access into the maxillary cavity, and we have access to the Schneiderian membrane, and we can lift completely, our goal is to get to this medial wall where we can get our blood supply. And that's going to feed our graft material. So we need to have some sort of a solution, if we're going to go from a Crestal aspect, to be able to match the same type of results that we can get from a lateral approach, so that we can have an implant that can handle forces under load for long term. And from the lateral aspect, we have many different ways to approach it. Piezo instruments have been on the market now for many years with different types of tips to be able to access the sinus cavity, whether it be a ball tip or a saw tip. There are trephine instruments that we can use to access the sinus wall extremely quickly, as well as diamond instruments or just a plain diamond burr that we can use on a high-speed handpiece to access the sinus cavity as well. And all these work very well and can be very successfully if we understand how to use them. So there's not one technique that is absolutely flawless. Each technique requires its own education to be able to figure out how to use that instrument and to open up our window. And from there, the rest is pretty much standard. We would use sinus curettes to elevate, lift, to get to the medial wall of the sinus cavity. In addition, there has been many advances over the years, and this was written by Dr. Scott Gantz and Rinaldi in their book in computer-aided applications of actually using 3D software, cone beam technology, to develop a sinus window. So we can actually pre-plan where we want our windows to be and use that and make it very, very simplistic to figure out the location to where that actual sinus access should be. And there are very good advantages to having the lateral window. And one of them is that it's not a blind technique. We can clearly see the sinus membrane. We can tell if there's a perforation. We can repair the perforation quite easily. We can fully elevate the palatal membrane with an instrument. We're not held back by the bounds of ergonomics from being able to reach all the different walls of the sinus cavity. Some disadvantages are that we have some higher morbidity because we have to raise a flap much higher up into the mucosal area. We can engage the branch of the PSA. We have to sometimes negotiate around septi. And there is always a chance of an oral-antral communication if the surgery goes wrong, which is pretty standard with all of them. But in a case like this where we have a septum and we have to negotiate around it, and we have a PSA artery, we can use the tools to be able to elevate and still accomplish these goals. It's just much more complicated in these types of situations, and you can see how we've been able to reflect around the septum and still keep the PSA intact and still complete our graft using some IPRF mixed with some cortical cancellous graft material, and then somehow play a little puzzle game to put our pieces back together and cover with the membrane, and we can have outstanding results to be able to lift the maxillary cavity to be able to handle implants of a long-term load. And of course, the lateral technique needs to be employed in several situations, such as retrieving implants. This implant was in my secretary's mother's mouth for over 30 years, and it dislodged, and so we had to go and retrieve it. Here's another example of where, in our course in Mexico, in Tijuana, where we teach live surgery, where we have one of our students actually removing a mucocele from the sinus cavity, which is easily accessible through the lateral approach technique. So we need to learn this technique. And especially if the other techniques go wrong, we have to be able to employ the lateral technique to be able to recover ourselves in these types of situations. So let's talk about the class 2, the low and wide. So for this, we can employ different kits. I personally like to use the kit from Megagen kit, and it's quite simple to use. We have these little express burrs that we can use. And very simply, the concept through this animation, we just simply pop a hole into the maxillary sinus cavity. We would use an instrument to just help dislodge the membrane slightly, and then use some curette instruments to be able to elevate and at the same time still get to the areas that we would get the same way that we can use through the lateral approach. We do not have to say that this is a closed type of technique. We are accessing the cavity, accessing the wall, and fully engaging it, being able to place bone graft into that location. So it's basically the lateral window. We just turned it sideways. And this is the goal. If we're going to be able to do a technique and say that it's as good as the lateral approach, we want to be able to say that we can accomplish the same thing that as if we're using the lateral technique. I think I've wandered too far off. I'm sorry, I can't sit still. This is my, and these are my friends here I have to say hello to, my wonderful instructors. So some advantages, it's not a blind technique. We're actually accessing the sinus cavity. We see the floor of the membrane. We can then elevate it fully as if we were using the lateral technique. It can be done simultaneously with extraction, and very often we can place an implant simultaneously through that cavity. Some of the disadvantages, it does require a wide ridge. To be able to fit an implant and still do this, we do have to have some extent of a ridge. I'm not going over there again. And it does require some specialized tools and burrs for us to be able to access that cavity. So let's take Tom. Tom's a patient of mine for many years. Great guy, firefighter, hardworking man. And he wants to get a quick, speedy solution. He doesn't want to have a long, drawn-out procedure. He heard about the lateral sinus lift several times. He had this is an implant placed. It was not comfortable for him. It was not a fun technique. And he was kind of shy, and so kind of let the rest of his mouth start to fall apart. But let's focus on this area here. So you can see there's an older implant there. The crown's not looking too great. This crown probably could use a change as well. And one thing we can notice in this area is that we have a depression. Right away we can tell that this is not something that's just going to be just a sinus lift, that we're probably going to have to do some GBR in this kind of a case. But on the cone beam evaluation, we can see that we actually do have enough width to be able to place an implant, but that our tip of more than half of our implant will be sitting inside the maxillary sinus. And here, we're going to want to fill that with something. So either it's going to be bone graft or connective tissue, and preferably I would rather use a bone graft since I'm already opening up a flap and getting involved into that location. So this is the Sinus Express tip. It's a dome-shaped type of a tip, so it's very hard to perforate the sinus. You can set it 1 millimeter past the sinus floor, and very simply, after using a drill just to make a purchase point, we can drill at about 500 RPM, and you'll notice just a quick little pop, and we can fall directly into the sinus and access the stridarian membrane. We inspect the sinus cavity by using the Valsalva method, holding the nose, having the patient breathe through the nose, making sure it's not torn, and then using a series of instruments. One very simple instrument to just attach the sinus floor, and then some curettes that we can now elevate. And I want you to notice something about these curettes. We're not staying just 1-2 millimeters past the sinus. We're going to take that instrument all the way up as if we were doing a lateral technique. We can climb up the wall completely. So this is very, very similar to the lateral technique. We're just using it from a different approach, from a 90-degree turn. We can then put some PRF into the cavity just in case there's some perforation. I always like to put something in there that we can't see, maybe some micro perforations. Followed by some bone graft. We use some fibrin glue that we take from the PRF and pack that into the sinus cavity. And this part should be taken with care not to push too far with the plunger into the packing tools so that we don't fall right through the sinus cavity. And then I like to use a drill just in reverse just to help move the graft around quite easily. I do pretty much everything backwards these days, which you'll find out in my next few slides. So then we're placing our implant in its location. And you can see that we do have some bone, and we're not going to have the threads completely exposed on the implant. So we will be able to do a simultaneously grafting procedure. And when we're using a specific type of a mesh material here, and it's called an iGen membrane, and what we want to do is be able to use a height connector to raise that up because we want this implant to be subcrestal. So we're going to put one type of an abutment directly onto the implant. Then we're going to just decorticate, place our bone graft, and you'll notice you can actually see the implant shining through the bone here. Place our sticky bone that we made from the PRF material. And then we can seat some PRF on top of that to help keep it stabilized, along with a titanium membrane that's going to give me the exact shape of a box that I want to have as a final solution. So this is a titanium membrane that's anchored on directly to the implant itself. And then it's just a matter of simple closure. And here's our 14-week post-op. We have the tissue. This obviously needs a little bit of attention, but we have a full sinus lift completely there. Our bone graft is incorporated. You can actually see the titanium membrane on the CT scan. Retrieval of this membrane is quite simple. We just take a tissue forceps and just pull it back and forth after we've taken off our healing abutment. Pull that off, and then we take out that flat abutment and place a standard healing abutment on top of that. At this time, I'm going to skip this, but we did do some soft tissue grafting, some apical repositioning and some soft tissue grafting. But what you'll notice here is that I'm using an Crestal device because I want to find out, is my implant ready? When can I load this implant? And I'm getting an excellent reading, so I know that I can restore this implant right away as soon as the soft tissue is ready to roll. So after some soft tissue work and some manipulation, we start to see the tissue is getting a little healthier. But look where we went from here to here, which is basically what we would have gotten if we had employed a lateral technique. And here's our day of insertion final crowns. We changed these posterior crowns and getting a nice tissue response. And all this was done in under 20 weeks. This case is now 5 years old, and I'm very happy to show that that bone is still in place and holding very nicely, along with the crestal stability of the implants, the bone by the implants. So there are many kits on the market, and remember, the key is to learn how to use the kit that you have. There are lots of kits, they all work. You just have to understand how to use them. So education of these kits are paramount. So lastly, I'm going to spend a little time on this one, about an hour and a half or so on this topic, on the class 3 high and narrow type of a implant. So typically, with this type of technique, we employ osteotomes. It's been a standard thing. We've been using this for decades. It was described by Summers, and it's a fast, convenient system to be able to place an implant simultaneously. We can increase the heights up to 4 millimeters. Some people will say even more. We can place the implant at the same time. We can condense the bone. We can densify that bone. But it does have some disadvantages. It's a completely blind technique. There is a possibility, because we're using a mallet, that we can develop a vertigo situation, which has happened to me on one patient. Fortunately, it was my aunt, and I think she was a little nutty before that. So we do have a requirement of a minimum of 5 millimeters of residual bone height, and we can't elevate the buccal and palatal membrane when we do this. We're going to have some type of a dome shape at the end. And this is the basic ideology behind it, where we would take an osteotome and hammer the floor. Show you a quick little video on hammering the patient. And you can see we have to get a little bit aggressive with these osteotomes to break the floor of the sinus. So not that much fun. I mean, if it was me, I'd really rather not have this technique being done on me. So I'm not a fan of hammers. Abraham Maslow said, if all you have is a hammer, then everything looks like a nail. So basically, it's the same technique. If we're using osteotomes and that's all we have, then that's all we can use. So we have to kind of think a little bit out of the box and come up with other solutions for this. And osteodensification, which has been exploding onto the scene of implant dentistry over the past few years, and I was happy to be involved for the last couple of years in watching its success. Instead of extraction drilling, we drill in reverse and densify the bone. And when we do this, if you look at a standard drill versus a osteodensification drill, you'll see what can actually be used here to be able to help us in the sinus. Look what's happening here. We're getting this hydrodynamic compression wave. There's like a tornado going into this site that's pulling it, almost like a vortex, pulling all this water down. Whereas standard drilling just leaves us with that type of a shape. And this is just a standard drill in reverse. So it's the design of these drills that's very important. And we can use this to help us try to elevate the sinus membrane without actually having to engage the sinus membrane. And we can elevate it in all directions, and you'll see how. So let's take this patient. This is Joshua. Joshua was a patient of one of our instructors on the trip. He's practiced in Brooklyn, and it was actually a good friend of his, so the oral surgeon did not want to touch him because he thought he wouldn't pay him. So he said, I'm going to send you to my good friend Isaac instead, because at least maybe I'll get paid. And you can see here, when he presented to him, he already had somewhat of a pneumatization of the sinus because the roots of the maxillary teeth are already embedded into the sinus cavity. So 6 weeks after, no graft was done. We simply look at the PA, and you can see that there's not a lot of room for an implant. So on cross-sectional analysis, you can see we have some defects, and that, in fact, if we were to go ahead and place an implant, that our implant would be sitting halfway through into the sinus, and this is just a standard 10 millimeter length implant. So we have to be able to employ a technique here that's going to help us elevate the sinus and densify the bone at the same time if we want to be able to place an implant simultaneously. And once we reflect the flap, you can see this type of a presentation. And there's categories of D1 to D4. This is D5 bone. You look at it and it starts bleeding the second you look at it. You touch it with your finger, it wants to compress. So we have these types of situations only 6 weeks after surgery of extraction. So in this case, we're going to use these burrs in a counterclockwise fashion. We'll use a series of burrs to help elevate the Schneiderian membrane. And in the beginning, with the first few drills, we'll stay 1 millimeter short of the sinus, but after some subsequent drills, we'll start to push a little bit past the sinus floor, 1 millimeter past the sinus floor. And we can actually place some bone graft inside at that same time and use those drills to help push up the bone graft. And since this was one of my first cases that I was doing, I wanted to take a mid-check x-ray and make sure and see how much I was lifting. And you can see what we went from here to here, just from the drilling protocol and adding just a little bit of graft material. We then went ahead and placed two NE1 implants. I really should have placed the NE ridges on these because they're a little more aggressive. I probably would have gotten a higher ISQ on them, but they did get some decent torque on them. And we just took a ISQ measurement. How many of you are using Ostel or ISQ in your office, just by a show of hands? So I should expect in the next few years, I should see almost this whole room have their hands with their hands up on this. This is a revolutionary technology with over 850 articles giving you this faster loading protocol with proven scientific background. It's something that's a game changer in your practice. There's no longer any guessing game, tapping the implant and trying to listen to hear a thud and see is this implant successful or not. No more reverse torquing. Use a scientific protocol to be able to give you an answer as to whether or not this implant is ready. As you can see, my Ostel numbers are not so high. Typically, we'd like to have numbers above 70, 75 to be able to place a healing cap on day of surgery. Even though I had good torque, I torqued out at 35 newtons. So I should think that maybe I would get a little bit higher of an ISQ, but I didn't. The bone was still a little bit soft. So I know that by having Ostel, I should be burying this implant. So which is what we did. We decided to close the flap over the implant. So we got a 61 and a 65, and you can see just how much elevation we've gotten from the original sinus membrane. And we decided to use, at this time we were already on to the A and IPRF. We decided to use the IPRF with our bone to create some sticky bone, and then soft tissue enhancement as well with the APRF membrane. And you can see after just 1 month how nice the soft tissue looks in healing. So 6 weeks later, only 6 weeks later, we re-enter. Look at our numbers. Much higher. These implants are actually ready to go. Now, I would have never entered 6 weeks if I didn't have ISQ because I would have no idea whether or not my implants were ready. I would think that they're still a little soft. So Ostel is really a great game changer, and I highly recommend looking into it into your practice. So you can see on the cone beam, post-cone beam analysis of this implant here, we have some good graft material well into the sinus cavity, and we're getting to the medial wall of the sinus with this hydrodynamic effect. On the other implant here, same effect. We're able to lift and get all the way to the medial wall. Our soft tissue response is excellent after placing healing caps, and we're loading this, and this case is completed in 3 months. That's a game changer for your practice. That's something that you can stand out and say, hey, I can give you an implant faster than the guy down the block, because the guy down the block, he's just using old technology saying, I'm not sure how long your implant's going to take to be ready, so let's just wait 6 months. No more arbitrary guessing. Use science to your advantage. So about almost a year ago, I was asked to come up with a solution for the Versa instrument and for the Densa burr. and go with a guided vertical solution for it, which we had completed very successfully and showed it at the Osteodensification World Symposium in Orlando in February. And it was a very good system. It worked out very nicely. So we decided, let's try to do a vertical sinus lift with this. And the key ingredient to this is that we use this vertical gauge stop so that we can use any type of a printer to print a guide. You can even use a Formlab in your office and print a guide. And basically how it works is we'll put this telescopic stop here, and then this piece here just turns to give you your length. So we can have a vertical control over the length of area where we want to go into drill into the site. So from here we can then control where we want to place lift our sinus membrane. And we designed a guide that would be open on the front. And it's very important to have this open on the buccal aspect. Why is that? We need to be able to see a visual inspection of the site. We want to make sure that the bone is actually expanding when we use osteodensification. So if we can't see and we're being blocked by having a guide that would be covered here, we can't tell if the bone is densifying or breaking. So we have to be able to see the bone itself. Secondly, and this for sinus lifting procedures is more important, that it facilitates water to allow to come in. The key to osteodensification is a pumping motion of the drill. By allowing this pumping motion, water is able to get to the apex of our osteotomy and be able to create that hydrodynamic wave effect that I showed you in the other video. So, decided to try this on a family member, because obviously that's the best people to try it on, first trying something out. So, we had a cousin who, I have lots of cousins, so I'm lucky I get to try a lot of different things. So, we had a cousin who, this tooth was failing, it was quite mobile, needed to be extracted. So periodontal disease all over and needed several implants, but we said for this, let's try to use our technique. So we extracted the tooth, we took it out, we decided to remove all the enamel and some of the decay there. A dentin grinding unit. And if you're not dentin grinding, this is another one of those game changers. This is not exactly from that case. But what we do is we can grind this tooth up, create a bone particulate, and use it for bone graft. So no more throwing out teeth. We have a healthy tooth that's non-endodontically treated. Why not grind it, place it back into the site? Why spend money on bone graft? And why put something far into someone's body when they can use their own tooth as a bone graft? And from a different case that I was doing a sinus lift, I had extracted several teeth. We got a little bit more than 3.5 cc's of bone from extracting 5 teeth. That was a pretty good amount. So we were able to do a complete sinus lift on a different patient, but just for video purposes. So we were able to make some sticky bone with the tooth using some of the fibrin glue from Joseph's APRF. But now we come back and we see if I want to place a 10 millimeter implant, we're going to have to do a little bit of a bump. So I said this is a perfect case to try this out on. Because worst case scenario, if I perforate, if I screw this whole thing up, I just put an 8.5 millimeter implant and call it a day. Everybody's happy. So instead of trying this on a case that really needed a lot of lift, I decided to try it out on the first one, take the easy road out, and have a backup plan just in case. So we made a seed guide, and this time we decided to go direct to resin, no more sleeve. And we used the telestop. You can see how it's going to stop on that sleeve. We placed it into the patient's mouth. First, I just wanted to get an orientation, so I drilled without opening a flap to find with my pilot, just to find my location. Then I decided to open up a flap so I can see what I was doing. And using the sequencing of the drills, and the sequencing with osteodensification is to drill, again, 1 millimeter short of the sinus at 1200 RPM in reverse, and again in that pumping motion. And then eventually we can go past that 1 millimeter. So using a few different burrs, we can now start to pass the sinus membrane just a little bit. By the third drill, we can actually go 1 millimeter past the sinus floor. You can see my guide's moving a little bit, so we have to hold it down so it wouldn't move. But now we can check to see if the sinus is actually intact. And look what happened. This was after the second drill, where I actually got too close to the sinus. And look how nice. I was actually happy to get this picture on the first molar. It's kind of tough to get it, but you can see the Schneiderian membrane. It's a glass-like effect This was after the second drill. By the time I used the fourth drill, you can see all the bone had been pushed up from the osteotomy, pushing back that sinus schneiderian membrane. So this is an autogenous sinus lift using the patient's own bone, just to try to get a couple millimeters. So now we're going to insert our implant freehand. So this was basically a template assisted, not fully guided, but template assisted. You can see we have a nice location. And here's our implant into on the CT scan. So we'll place our implant flush, just subcrestal to the bone. And then we're going to take an ISQ. The ISQ actually was quite excellent, but I want to show you this more importantly, is look how these pieces of bone were pushed up into the sinus cavity. It's only a couple millimeters, but good enough. 6 weeks later, taking impressions, I have an ISQ of 80. I like to flow some some composite material around my open tray impression copings, try to capture in the margins for just in case we have purposes like this, where we have a void in our impression. I don't have to care about this. Here's my sulcus. Flowing some flowable composite around my transfers, I can capture the sulcus quite nicely and have a good, nice emergence profile and not have to care if all my impression material made it all the way around the tooth. So we developed the crown, screw-retained crown, placed it into the mouth, fit quite nicely, and you can see here's our old sinus and here's our new sinus. Bumped it up just about a couple millimeters. So the next step was to say, that was easy. Let's try to do this fully guided. Let's try to get an immediate placement, fully guided. And at the same time, why don't we try to load the implant if we have a great ISQ? So using the standard the CAD/CAM designing software, we make our sham software, output the STL, put it into a CAD/CAM solution, and we can design our final abutment. We can print in the office. We actually use a Formlab 2 to actually print the surgical guides. And we're going to make 2 guides here. And we can actually design we can actually mill our final abutment. If you have one in your office, you can do it straight from your office. So this patient had a failed implant many years ago, has 5.5 millimeters before the sinus, and we said, let's give this a go. He's a good patient, and he's not a cousin. So we said, let's try it out on him because he is actually a very good friend of mine as well. So raise our flap, very simply lift through, and now here's the key. If we want to go fully guided, we can't use just the Versa drill. We need to use another system. So I'm using Megagen, so I use a R2 gate guide. And I use my pilot drill so I can get a perfect positioning with my initial drill so that I can hold, even with my Versa guide, I'll have no movement with my drills upon using the denser drills. We'll be able to stabilize it. So this is the Versa C guide again. We're now going to take the first guide out of the mouth. We're going to employ the Versa telescopic stops. And very simply start in the same fashion. Stop with our drill 1200 RPM in reverse, stop 1 millimeter short of the sinus with the first drill, and then with subsequent drills go 1 millimeter past the sinus floor and widen out our osteotomy. So here's our third drill, and we're going to start going past the sinus floor. And again, that pumping motion is very important to allow water to reach the apex, fill the osteotomy, and create that hydrodynamic wave effect. And after using about 4 drills, we can now have after using the rest of the drills, all 4 drills, we can now start to engage and place our graft material. So before placing our graft, we want to check that the sinus floor is intact. And since I'm doing a reverse drilling technique, all the bone is already there. I know I have no perforation. But just in case, we took a really good picture to make sure that there is bone there. So sinus is completely intact, and it's filled with the patient's own autogenous bone. But now I need to lift. I want to elevate the sinus. So we're going to use some NovaBone. It's quite easy to handle. You just put it in a cartridge, and you just squeeze it right into the osteotomy site. In the interest of saving time, I did this in split screen so we can see how many times I used it. I used it about 4 or 5 times before placing the implant, and each time going in with the Densibur to help push it up. Again, you can extend more than 1 millimeter past the sinus floor. At this point, we can go up to 3 millimeters past the sinus floor and just keep adding bone and elevating that membrane completely. Now I have to go back to my fully guided solution. I go back to my R2 gate guide, and I place my implant directly through the guide, so it's now completely fully guided, and it's not template assisted any longer. And we have our implant in the right location. So next step is to see if we can load this. How am I going to know? Ostel is going to tell me. So I use my Ostel, and we're hoping for a good number, keeping our fingers crossed. Let's make sure we can use our abutment, and sure enough, we get 81, and I think 82. So we're rocking and rolling, ready to go ahead and place our abutment. And if you're into the one abutment, one time concept, which we've been trying to do, that's what we did. We placed our zirconia abutment into the mouth. This was designed completely on a resin base and confirmed. We have a resin crown, temporary crown. So we installed our zirconia abutment. To be honest with you, I would have liked a better contour here, but for the first case, it was pretty good. And now we can seat our resin crown over, and just like that, we can now cement that and even turn into a screw-retained crown if we wanted to as a temporary solution, which is what I did because I wasn't thrilled with the actual abutment design. You can see here why. I'd rather this have much more of a nicer emergence profile, more of an S-line curve. But take a look here. Look what we've done. We've lifted from here to here. And that's all without having to use any instruments other than a burr. And when we look at our post-op cone beam, you can see that we've been able to fill the sinus cavity around the implant. So, in short, this is still a new case. We have some little more work to go, but we do have the solution to be able to do a controlled sinus lift with immediate loading the same day. So, in summary, we do have these 4 different types of clinical presentations of the sinus. And for my recommendations for these procedures, for the class 1, I always recommend a short implant if the patient will agree, because I'm a big fan of them, and if we have the width, it's certainly worth doing. The class 2, we can use different kits to make a Crestal window, take that lateral window and just change it 90 degrees. For the class 3, we have the osteodensification protocol using Versa-guided drills to be able to place our implants. And lastly, Old Faithful for the class 4 and those narrow and low ridges to be able to do our lateral windows and access maxillary sinus in the more conventional fashion. Just want to thank you all for listening and coming today.